explain direct ophthalmoscopy. There are many different types of ophthalmoscopes available. Keeler has the professional and specialist set. The specialist is the one Valerie will be using today. Valerie also has the Welsh Allen Panoptic ophthalmoscope and the standard Welsh Allen ophthalmoscope at her disposal. The Welsh Allen Panoptic ophthalmoscope is banned from student exams due to it being too easy to use. Now you will be informed about apertures and filters.
We're now going to talk about apertures and filters. Large aperture. This is not often used because the increased area would cause pupil constriction. Therefore, it's likely to be used with dilated pupils during general examination of the eye. Medium aperture provides a detailed view of the fundus through an undilated pupil. Macular stop allows quick entry in the small undilated pupils. A slit aperture is sometimes provided to determine elevation or depression of a lesion using the monocular cue of the beam bending.
Some instruments also have settings that will project a target with a light beam, such as an eccentric fixation target. A green-red filter increases the contrast of blood vessels and vascular lesions. They appear dark against the light background of the fundus and therefore can be useful when assessing patients with diabetes or other vascular diseases. Cobalt blue filter can be used with fluorescein dye to view small lesions, abrasions or foreign objects on the cornea. Some ophthalmoscopes have a polarizing filter and a half-circle aperture. These are often available to decrease annoying reflections from the corneal surface.
Alright, I've just washed my hands before doing ophthalmoscope, and then we will have to dim the room lights. Alright, and then now I'm going to raise the chair. Alright, Hafsa, could you please look at the top corner of the mirror?
We take a systematic approach to assess the eye. We start looking from the anterior to the posterior of the eye. We start with a +14 lens and we look at the external eye. We look at lids, lashes, punctum, conjunctiva, cornea and record any clinical features. We then reduce the plus to 12 diopters and look at the anterior chamber and the iris. We reduce the plus even more to at least +9 and look at the lens and any media opacities. We ask the patient to look left, up, right, down, and if there are any media opacities, we see if they move with any head or eye movements. We also ask the patient to blink. We write down the plus a bit more and look at the vitreous. We ask the patient to look up, down, quickly, and this will agitate any material or debris so that we can see them. We then reduce the plus even further by looking more posteriorly to the eye to assess the fundus. We are now at 0 diopters. It is important to remember that the further we move into the eye, we keep reducing the plus.
Racking down to a plano lens, if the patient is emmetropic, we are going to check the optic disc. We'll begin by checking the cup to disc ratios. We'll check horizontally and vertically. The colour of the disc is also assessed, and in a normal healthy patient this should be pink and orange. The isn't rule is checked to check for any glaucomatous changes, so we'll be checking the thickness of the neuroretinal rim inferiorly, superiorly, nasally and temporally. We'll also be checking the dioptric depth of the cup, and 1 diopter corresponds to 3 mm depth. Inside the optic disc we will be checking for blood vessels, so veins will appear darker and thicker and arteries will appear lighter with a bright streak reflex going through the middle. And to also check for any pigmentation or thinning of the retina, we'll be checking for any temporal or pigmented crescent.
We then check the periphery to ensure that it's uniformly pigmented, check for the AV ratio and any nipping or pigment deposits and inflammation. So we tell the patient to look up to the right, to the right, and down right, and down to the floor, down left, to the left, up and to the left, then up again. Now we just change to the macular stop, and the clinician is going to focus at the inferior temporal disc and tell the patient to slowly look at the light. We should be able to see a bright yellow reflex, and we will also look at the color of the macula and check for lesions or pigment deposits, and we should also confirm that the macula is free of any black vessels.
This is the recording sheet we use at university. On the left side of the page we record everything we see in the right eye, and the right side of the page we record everything we see in the left eye. The space on the sheet allows us to record details of what can be seen in all structures throughout the eye. The diagram on the sides allows us to draw the central and peripheral blood vessels if necessary. It is important to record everything that is seen on the sheet, as if it is not recorded, an examiner will think it hasn't been checked. Also, all findings must be written in pen and not pencil.